Advanced lung adenocarcinoma remains an exceptional example for precision medicine and oncology as we persist in exploring new therapeutic targets and evaluating new ways to sequence and combine novel agents. In this OncLive peer exchange discussion, Future Directions for Precision Medicine and Advanced Non-Small Cell Lung Cancer, I'm joined by a panel of my colleagues in thoracic oncology clinical research. We will delve into some of the latest data surrounding the use of targeted therapies in non-small cell lung cancer, including research being presented at the 2018 World Lung Conference on Lung Cancer in Toronto, and we'll talk about the practical implications for treatment of metastatic disease. I'm Dr. Benjamin Levy, Assistant Professor of Oncology and Clinical Director of Medical Oncology for Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Participating today on our distinguished panel are Dr. Lumela Basanova, medical oncologist, professor of medicine and lung cancer team leader at the UC San Diego Moores Cancer Center in California. Dr. Shirish Gajil, professor in the Department of Internal Medicine, Division of Hematology Oncology at the University of Michigan. Dr. Mohammed Jahanzeb, professor of clinical medicine, medical director of the Sylvester Dealfield campus at the University of Miami Miller School of Medicine. And Dr. Ann So, professor and director of the Mesothelioma and Thoracic Chemoradiation programs at the University of Texas MD Anderson Cancer Center, Department of Thoracic Head and Neck Medical Oncology. Thank you so much for joining us, and let's begin. So thanks for everyone coming. I think we're going to have a very robust and interesting discussion today. We'll start out with EGFR. EGFR is a relevant mutation in roughly 15 to 20% of advanced non-small cell lung cancer adenocarcinoma, at least in an unenriched patient population. We know that first or second generation TKIs outperform chemotherapy in an EGFR mutation positive patient in terms of response rate and progression-free survival. But we've seen some practice-changing data over the past 12 to 18 months that has really begun to alter again the therapeutic landscape. And one of those practice-changing, some of the practice-changing data has to do with, of course, osimertinib. So Anne, you want to talk about the osimertinib data and where we are with that right now?
So osimertinib is a third-generation EGFR tyrosine kinase inhibitor. And the FLORA trial was actually comparing osimertinib to the investigator's choice of erlotinib or gefitinib, which is our first-generation EGFR tyrosine kinase inhibitors. And it was a one-to-one randomization for patients who had sensitive EGFR mutations. So that's your deletion exon 19, L858. And so these patients were randomized one-to-one to receive osimertinib or either gefitinib or erlotinib. And the bottom line to this study was there was an incredible, impressive progression-free survival benefit with the osimertinib. The response rate was pretty equivalent, about 80% and 76%, but the median PFS was significantly prolonged at 18.9 months with the osimertinib compared to about 10.2 months with the first-generation EGFR TKIs. And so that translated into a hazard ratio of about 0.46. Yeah. And so this certainly, although the data is still immature, also translated into an 18-month median OS benefit. And the hazard ratio there, I think, was about 0.6. Yeah. So clearly, you know, at least in my practice, I changed to give osimertinib frontline for all of my sensitive EGFR mutant patients.
Yeah, I think it was compelling, the PFS advantage. That was a little unexpected. That PFS was actually fairly commensurate with the phase 1 osimertinib experience. The CNS activity also.
Absolutely. So that's also the additional benefit that we saw, is that there was a delay or prolongation until time of first CNS event. And I'll be honest, you know, in many of my patients who I treat frontline that have CNS metastases, I don't send them to radiation necessarily anymore. I'm giving them osimertinib, and then I see if we can get the CNS mets to regress. And in the patients I've done it on, so far so good.
Yeah. Let me ask you about that, the CNS metastases and what your trigger is to give radiation up front or not. Is there a threshold where you're not comfortable with the activity we've seen here and these patients may need SRS or whole brain before instituting osimertinib frontline?
Yeah, absolutely. So the cases where it would be the same as before. For instance, if a patient has any sort of impending herniation, you just don't have time to consider osimertinib in those cases. If it's small enough that they can go for a craniotomy, that's still what you should do. And also if there's a large enough CNS lesion that they have neurologic complications, I just don't think that you have time to wait for osimertinib to work, and so I still SBRT those patients. The only change that I do is I hold off on whole brain radiation. I try to put that off however long I can. And so it used to be that our EGFR mutants used to have this diffuse brain mets across both hemispheres. And we used to do whole brain in those patients. I don't do that anymore. Okay. And so in those, I will just go ahead and give osimertinib.
And you know, the third element I think of this trial that was exciting was the adverse event profile with this drug in the context of what we generally see with first and second generation TKIs. Any comment on are you seeing any adverse events, and maybe I can throw this to the panel, that weren't reported in the trial, or things that we have to look out for with this drug?
So a lot of our patients love this, right? You don't have the rash, you don't have the terrible diarrhea. I mean, to a small degree, you might get a little bit of it, but certainly nothing like the prior EGFR TKIs. The only word of caution I have is you can potentially get some QTc prolongation. So in a patient with a prior cardiac history or a known QTc prolongation, I always check an echo and EKG just to be sure, and I try to get rid of any other concomitant meds that could potentially lead to problems there.
I've seen some cytopenias. I don't know if anyone else has seen these in their experience.
A little neutropenia.
But none that led to any clinical consequence. It was mainly laboratory-based. If I can quickly chime in, going back to the CNS, I think an important practical implication of some of these drugs, both in EGFR and ALK space, having CNS activity is that many times we know the patient has brain mets before we know the molecular alteration. And I think it is important that the reflex should not be that if brain mets are seen, that, I mean, one can refer them to radiation oncology, but they may not be initiated until we got the full results of the molecular analysis back. And once we've decided what systemic therapy we are going to use, then decide what treatment should be done for the brain mets.
I would agree with that. I think there's an opportunity for education to our radiation oncologist on this to make sure that they're aware of the data. And the data is fairly new over the past year, so there is an opportunity here to make sure that the radiation oncologists are aware of the CNS activity so that we can hold off, if possible, in giving an active drug both below the neck and above the neck.
And I would draw a distinction that at academic centers, it's easier to educate radiation oncologists who are embedded within the tumor board, but in the community where these patients may be seen by the oncologist who sees a whole range of disorders and all cancers, they see one such patient a year, they should perhaps refrain from referring the patient to the radiation oncologist until there's a real need. Because I think it becomes very difficult once you send the patient to the radiation oncologist and they start planning radiation to then undo that activity. Patients say, well, the other doctor wants to radiate, what's going on, you guys don't agree. So I would just say that if you don't think patient needs urgent radiation, we should all wait for the mutations ideally.
Underscores the importance of tissue genotyping and get that answer in a relatively quick fashion.